a good idea as far as what kind of treatment can we do, and if we do that treatment, what kind of outcome can we expect. So in a class 1 and most class 2s, we can expect to get really good root coverage, and a gingival graft is indicated in these cases. So we can expect on those 1s and 2s to get good restoration of keratinized tissue and good root coverage. The big difference between the class 1 and 2 and class 3 is that interproximal loss. So when I'm evaluating a patient with this recession, I'm looking at that interproximal bone as kind of a guide, or the tissue itself as a guide of how high or how much can I, coronally restore gingiva. So how I explain it to patients is I imagine like hanging a curtain over a window, and the bone or the tissue interproximal on the tooth represents my 2 pegs that I place on my wall to hold my curtain, and then my curtain hangs down between it. So in the bone, right? We know the bone, like we talked about positive architecture in a normal healthy person, you've got interproximal bone higher or more coronal than you do the buccal bone. And the gingiva typically follows that bone. So there's a term that we say bone sets the tone. So bone is going to determine in this case, if I look at that number 1 on class 1, they've got bone interproximally. They've obviously lost a little bone on the buccal, but we're going to try and restore the gingiva there to cover that. Anyway, going back to that, I hang my curtain with my 2 pegs. My 2 pegs are in the proper space, the proper place, and the proper height, then my gingival tissue is going to cover that root, and it's going to look nice and normal. When you start getting into class 3s, where you've got your pegs, 1 peg may move down, okay, and now my gum is going to move down with that, and it won't be able to get up as high. So you're losing the ability to totally restore gingival health as you lose interproximal bone, because the interproximal bone is what's going to give you the stability and the height to which you can go. A good estimate is I can measure about 3 millimeters down from the tip of a papilla, and that's going to be, like, in most cases, the maximum height I can get. So if you measure the papilla on a class 3 and go down 3 millimeters, you're still going to have some recession on that buccal because you don't have the proper support interproximally that you need to restore that. Another thing to note is, if I were to treat a defect, I would rather have a little bit more of a narrow defect than a wider defect in these, just because I can cover my graft better and get blood supply to the graft and restore that. The difference between a class 1 and a class 2, obviously, is that mucogingival junction that comes into play when we're flapping and doing different things. But typically, we can do a pretty comparable job in a class 1 versus the class 2 as far as results and healing. With a class 4, there's not a lot we can do to restore gingiva there because of the bone loss, typically horizontally, or a pretty severe vertical loss. We can do some like a free gingival graft, which we'll talk about in a minute, to try and increase keratinized tissue, but our root coverage on these cases is really not going to be very good, and it's not predictable at all on a class 4. On a class 3, we can do some grafting, but we have to just explain to the patient and set their expectation as far as we're not going to get total coverage on these roots. Any questions on that classification? Okay, awesome. So the first surgery that we'll talk about is what's called a subepithelial connective tissue graft. So this is a gum graft in the sense that you normally hear it used when people say I had to get a gum graft. This is likely the graft that they received. The primary use for this is to cover an exposed root surface. And so typically we combine it with some coronal positioning of the flap. And so we're trying to cover exposed root and increase keratinized tissue in the area. So the technique, so this is, we'll go through a couple pictures here, but there's a lot of different ways to do this, but so we're just going to try and get the general idea of what's happening. And so, if you Google it or go to YouTube or, go to a CE course, there's going to be lots of different ways to achieve what we're trying to do. But I'm going to give you just kind of an overview so that we can hopefully understand a little bit better what's happening. So typically the first thing we do is we prepare the teeth. So we root plane and clean the exposed root really good and the area around it. And the reason for that is we want to prepare that root surface so that it can be clean and healthy and get some reattachment. So when we remove any calculus or bacteria, we plane the tooth a little, so we remove some cementum, and we're doing that so that we can expose nice, fresh, healthy collagen, so that when we put the graft on as it heals, there's a connection there, and we get some reattachment. So we use a split thickness flap, meaning I'm not necessarily trying to remove all the periosteum. So we're essentially just creating a flap or a pouch or envelope for the graft to be placed into. And so this can be done with, we use a blade to do incisions, both sulcular and vertical if we need it. And we use some instruments to essentially release the flap and loosen the tissue around it. A traditional flap design, again, would be we can release some of the papilla, do some verticals, or in a tunnel procedure, and I'll have some pictures of that. We can actually leave the papilla intact, but undermine them and kind of loosen them and loosen the tissue around, creating like a little tunnel that we can place our graft into. So we prepare the site, we clean the teeth, we get our flap ready and prepare the recipient site, and then we harvest tissue from the palate. So typically there's again different ways to do this. You can do what's called the trap door, where we actually make some incisions in the palate and pull the tissue back and remove connective tissue, or the parallel freehand or the Harris knife, which are essentially using blades to remove a section of tissue. Again, I'll have some pictures and we can talk a little bit about that. But we take the tissue from the palate, okay? And then that graft is placed into our recipient site where it's sutured, and we try to coronally position that graft to at or above the level of the CEJ. So we're trying to cover up as much as we can, and then we replace our flap, and we coronally, either we replace it where it was or coronally position. I typically try to coronally position just so I can cover as much of that area as I can on the defect, so that we can get as much root coverage as possible. So just this photo here. Oh yeah, go ahead.
On the palate, when you're harvesting that piece of tissue, how do you nicking an artery or nerve?
Yep. So that's a good question. So typically I try to I don't go further back than the first molar. Okay. So when I'm doing my harvest, I stay first molar or mesial. Okay. And so that kind of keeps me away from that greater palatine area. Okay. And then when I'm making my incisions, I'm typically trying to stay as close to the epithelium as I can. So I'm not trying to be very deep as far as towards the periosteum or towards the palate. And I'm staying up towards the teeth. So we're not necessarily taking our graft from like the roof of the palate, but I measure about 3 millimeters down from the free gingival margin on the teeth and make my incisions along that. So it's more towards the side near the teeth. And I'll show you a picture, and hopefully that'll make a little more sense. But it's a good question. I'm definitely mindful of greater palatine. I'm typically not coming all the way up to like the nasopalatine unless I need a really big graft. So I'm careful there as well. But those are some of the precautions I'm using and trying to avoid that stuff.
And you would use greater palatal nerve block to.
Correct.
Yeah.
Yep. And I'll usually give them a little in the nasopalatine in case I get up a little further. Yep, but a greater palatine is typically enough. I'll also just give them some local right around the area. I'm going to take the flap just for like hemostasis and just controlling the bleeding a little bit.
All right, thank you.
Yes. How long can the tissue stay outside the body before it becomes necrotic?
So as little time as possible, I guess. But typically, you probably have about, I don't know if I know a number right off the top of my head. I'd say 15 to 20 minutes, maybe a half hour. But like I try to have everything ready, right? So I do the site preparation first before I take the graft. So I get everything lifted up and my flap elevated, and that way I can at least start tucking the graft in right away. So it's bathed in blood and in their mouth. Okay, does that make sense?
Yeah, thank you.
Yeah, I don't know. I don't know off the top of my head. I don't know an exact number of like minutes, but that's typically about. I have to take a few minutes to suture the palate and stop the bleeding, and then I place the graft in. I keep it hydrated, so typically, I have like a little stainless steel plate that I can put it on, like a little. It looks like a credit card, and it's got measurements on it and stuff. But I just put it on there, kind of keep it moist with saline, and then cover it with a wet saline gauze, and then I can, that normally does just fine.
When you when you remove that area of tissue from the palate, does that epithelium regenerate, or do you just have a defect within the palate?
Yep. So it'll grow back. For a little while, there'll be like a little divot where it came out, but typically it grows back, and people, it just looks normal for most people. There's no they don't notice anything, and it looks fine. Some people will have a little numbness for a while as the nerves grow back, I've never had anyone, knock on wood, have it permanently, but that's a small risk. Although that's a little, it's most people don't notice that on their palate. Like they don't notice that sort of stuff. Whereas obviously like an IAN, they're going to, if they damage their inferior alveolar nerve, they're going to have numbness in the cheek and teeth and things. So obviously I'm not trying to do any of that stuff. And some people do get a little numbness as it doesn't come back as quick, but they usually just end up fine, and there's no long lasting effect.
And is it like fibrotic, like scar tissue that grows back in that place, or is it just like normal epithelium?
It'll grow back normal. Yep.
Okay, thank you.
You can actually go back and harvest more connective tissue after about 8 weeks from the same spot.
Awesome, thank
Hopefully
you.
You don't need to, but you can. So, okay, good questions. So let me just show you, this is just a picture, just kind of a before and after. So you can actually see here before gosh, I can't draw. Is this okay? Is this view okay? So I can have my little mouse for a minute and I'll go back. Can you still see it, what I'm showing you?
Yeah, it's good.
Okay. So, initially we have some recession here. So this is a tunnel procedure. So what we've done is we've come and I've made incisions through here, okay, in the interproximal. So I'm not cutting through this papilla. I'm just doing an incision here around the tooth, here around the tooth, and here. And then what I do is I have like a little instrument. It looks like a little blade on a handle, almost like a little spatula kind of, but it's sharp on the end. And I press it through the sulcus here, and I can kind of sweep it through all the way through here. I can sweep it up this way, and I actually push it through, and you'll see it come out the sulcus on this tooth. So we undermine this papilla, and we do the same thing here. We come through, I'm moving my picture now. and loosen all of this tissue and loosen this tissue here, so that then everything's kind of loose and I can pull on this tissue and move it. So that gives me a little pouch here. So here's my graft, okay? So I can put my graft in and I tack it down with a couple of stitches. So we suture through the flap and through the graft to hold it in place. And then typically, it's not shown in this picture, we can do a few more sutures to actually pull the tissue up here. So here's your flap right here. And we actually coronally position the flap up. And as it heals, you know, we got some root coverage here. But again, the challenge on this tooth, as you can tell, was that it was a little rotated. So this tooth, it's hard to see exactly in this picture, but like this line angle of this tooth is more buccal than it is to number 26. So you're going to have a difficult time covering that totally due to the position of the tooth. But you can see the graft tucked here, and then as it heals, everything heals in nice and looks nice and pink and matches well. Now, when we look at the free gingival graft in a minute, that is not as aesthetic as a connective tissue graft, and you'll kind of see why.
Dr. Jensen?
Yes.
With that amount of rotation, is that enough to say that's like class 3?
Yeah, I would probably say that's a class 3. You don't necessarily have interproximal loss, but you have a little rotation on the tooth.
Okay.
And so the classification, again, I don't want you to get caught up necessarily on that. Like, as far as what I normally do is I take the worst thing, and that's the classification. So like on this, it's a little rotated, so that's class 3, right? And I would tell the patient, hey, you know, our challenge here is going to be you have a rotated tooth, and we have to do this, and it may not be 100% root coverage.
That's more of a patient management like expectation.
Right.
And then with this, it looks like you placed the graft a little bit higher than it ended up finally taking. Is that typical?
That can happen, especially like with a rotated tooth. And that's why I try to get it up. I try to put it up as high as I can, because I know there's probably going to be a little dieback in a lot of these cases. And so we try to, you know, coronally position as much as we can.
Okay, thank you.
Yep. So let's see. I might have to go and hang on just a second. I might have to pull up another picture so we can look at the harvest. I'm not sure I have one in here. Okay. All right. Well, here, this is just another example. So in this example, we actually do a flap. We did a flap here. So we've released this papilla here, okay, and this papilla. So we've pulled those back and actually done a flap. And then we've laid our graft here, right across there. Okay, so the graft then slides up under the flap, and we reapproximate our papilla. Okay, so see how it's resting up a little higher. Okay, and this photo is about 2 weeks after. Okay, so at about 2 weeks, typically this tissue will look like a tumor almost, like it's swollen and kind of yellow and pink and red and a bunch of different colors, and that's normal for it to look that way. So again, with like patient expectation, I'm just, number one, I tell them not to mess with it and don't look at it, because they want to get up there and move things around and do different things, and that can really compromise what's happening when they start to move everything. And so we try to stay away from that. But you can see how this is healing really nice. Looks like we're going to get good coverage on, you know, this tooth here, and even this canine is healing in real nice right there. So give me 1 second. Let me pull up another picture here.
Quick question: when you release the papilla, do you release it on the buccal side, or would you release it on the lip?
Yep, just the buccal. I don't need to do the palate on these. So it's like a traditional just buccal flap.
Okay.
Yep. Give me 1 sec. Let me.
Dr. Denchen, when you say subepithelial connective tissue graft, are you removing the epithelial layer before you put this in the recipient site, or?
So you don't have to, but what the subepithelial means is I'm not necessarily bringing a bunch of epithelium with me. Does that make sense? So let me show you this picture here, and I think it'll make a little more sense. Let's see, share my screen again. So this is showing my harvest of the graft. Okay, so essentially what I've done is I've made I use what's called a Harris knife. So a Harris knife is essentially a scalpel handle with two scalpels, and they're spaced. You can buy them different spacing apart. Mine the one I like to use is a millimeter apart. So you have two 15s that are 1 millimeter apart. And so this is number 14 back here, 13, 12, 11. So essentially what we do is I take those blades and I'm almost parallel to the long axis of these teeth. And like I said, about 3 millimeters below the free gingival margin, I go into the tissue. I try to keep my blade as close to the epithelium as I can here, because I want that connective tissue lays right underneath that epithelium, and I move it forward. So I move it medial towards the midline, and then when I have the measurement that I want, so I'm going to measure before I cut, and I mark it on my palette, and I make that incision. Once I get that done, I have to make 3 more incisions. I have to release the mesial, okay, because it's still attached there. I release the distal, and then I have to make a cut on the apical to pull this piece out. So this is the graft coming out. So there's a strip of epithelium on the top of the graft, okay? And a lot of times I'll trim that off just because it looks a little better. It's not as ragged, because you might have a little rugae or whatever that's happening on the top here. Essentially that typically will slough off anyway. When I put the graft in, the epithelium layer will kind of peel away. So a lot of times I will trim that off. But everything below that millimeter is connective tissue, and sometimes you'll have a little fat there as well. So does that make sense on that question about the epithelium?
Yeah.
Yeah. So the other way to do this, like the trap door. So the freehand is the same as the Harris knife. You're just using one blade and you make 2 incisions. A trap door incision is let's see if I can. So we'll get into this in just a second, but I'm just showing you a picture of a palette. So a trap door is you would make an incision here, here, and here, and then you would basically peel back that epithelial layer, so it would open up like a trap door, and then you can cut out some connective tissue, and then you place the door back and suture around it. Okay, so that one actually closes up. This technique, we do a little suture, but there's about a 1 to 2 millimeter strip of wound, and that's typically that's what most people will complain about as far as their discomfort is the palate, whereas where we place the graft typically isn't as sensitive or tender. So this is I'll just show you this picture. This is something that we can do with these things. Okay, is cover a nice good amount of tissue and get some good keratinized tissue there. So it's a good treatment, and most patients do pretty well with it. Obviously, everybody's a little different, and they're all going to have different pain thresholds and things, but most people do fairly well with this, and they're sore for 3 or 4 days, but afterwards they do really well.
With that trapdoor approach, with that trapdoor approach, how do you secure that tissue afterwards? Because you're only removing the subepithelium, right? So then
so that you lay the epithelium back. You just suture, just along the edges to the palate. Okay. Yep. I don't normally do that. I usually use the Harris knife. Okay. That's just kind of how I was trained. So typically when we do the gum graft, when things have healed, the connective tissue graft, if we were to histologically look at the attachment to the root, most of it will be long junctional epithelium, but there is evidence that there's some small windows of connective tissue attachment. So again, we talked about this in our last lecture. connective tissue is the natural and normal way that we want to see, but lung junctional epithelium is good and is maintainable and can give us health for a long time. There's also something called creeping attachment that has been noted in the literature, and this is noted as increased gingival root coverage over time following the surgery. So occasionally you'll do this graft, it'll heal. Typically I see people at 2 weeks and 6 weeks, and at that 6 weeks, everything's pretty much healed to where it's going to be. But you may actually see an increase in coverage over the space of a year to 2 years, or maybe even a little longer, but you may see up to a millimeter of additional coverage over time if it's clean and they do a good job. But it's very unpredictable, so it's not something that you can bank on. But there's a term just to be familiar with called creeping attachment, where over time, after the gum graft, they may actually see some increased attachment. So acellular dermal matrix. So the most common brand name for this is Alloderm. This is an alternative to connective tissue grafting for patients that either don't want to take tissue from their palate, or maybe they have multiple teeth or an arch or a quadrant that needs to be grafted, and that's a pretty big graft to take from the palate. So this is an option that we can use. Essentially, the tissue is taken from a cadaver, and they treat it and disinfect it and remove the cellular material from the graft. But during that, they preserve all the elements necessary for revascularization. So you have like collagen and some extracellular matrix that is preserved, and that then, like a bone graft, gives the body a scaffold to build into. Typically, this tissue will remodel into the patient's own tissue over time, and typically about 3 to 6 months. Again, so the epithelium, the epidermis is removed, and then the cells, they wash it and solubilize the cells, get rid of them, and then they cryogenically freeze it. So when it comes to when you order it, it comes in a little package, and it's like a little stiff piece of cardboard is what it kind of looks like. It's just a little white tissue, yellow tissue. It's, like we talked about, the biochemical and structural components are there and they're preserved, but the cellular material is removed. You have to rehydrate it when you get it. So it's 2 10-minute baths in saline. So like when I have the patient come in, I open it, I soak it while I do anesthesia and get them ready that way. And then we change the bath as we get the recipient site ready, and then it's ready to go. There's 2 sides to it. They have what's called the basement membrane side and then connective tissue. So the connective tissue side will resorb blood, and you can actually see it. You can take a little blood from their mouth and put it on both sides, and one side will suck it up, and the other side you can kind of rinse it off. Typically, you put the connective tissue side towards the blood supply, so towards the flap, and the basement membrane against the tooth or the bone. As far as healing goes, histologically, they're similar to a connective tissue graft. However, typically the alloderm will contain more elastin. If you looked at it under a microscope and stained it, you'd have more elastin. One trick with alloderm, and one of the challenges with using alloderm, is it has to be totally covered by the flap in order to heal. So you can see when we did the connective tissue graft that some of it was exposed, and that's fine. With an alloderm, you have to totally cover it or it won't survive the process. So you have to totally put it under the graft, or I'm sorry, under the flap. So this is just a couple pictures illustrating this. So you can see where we put the tissue in the bath. I'm doing a tunnel procedure here. So I'm making incisions interproximally on those teeth. And then that bottom right picture, you're seeing my probe, and I'm at about 12 millimeters there up into the gingiva. So that's just showing you how we've loosened everything. Okay, and essentially that tunnel extends up to those premolars, so I can kind of push and pull everything through there. And then this is just showing I've basically put the alloderm under the flap in that tunnel, and now we're pulling that tissue down around. So you can see the recession on number 2 on that picture, and then here we've pulled everything up to that CEJ, okay? And that graft, it looks like we've extended it up to number 4, and we've totally covered it. So that's what has to happen. What you're trying to strive to do with alloderm is cover that graft.
How are you stretching the gingiva? Are you cutting to loosen it or something?
Yeah. So when I make my incision on that lower left, then I take that instrument that I was telling you about, looks kind of like a little spatula or a knife, and I go up into that tissue and essentially use like sharp dissection to create that tunnel. And because I'm up into that mucosa, then that's all loose. So all that tissue will then move down. Does that make sense?
Yeah. So you're taking it past the mucogingival junction.
Yeah. So that like.
Go ahead.
Go ahead. No, go ahead.
Oh, I was going to say, so then you're basically just pulling the free gingiva. It'll just be tighter in the final result.
Yeah. As it heals, it'll retighten. Yep.
Okay.
Yep.
Could you do this with that allograft, that alloderm? Couldn't you just loosen the tissue and then reposition?
Without alloderm?
Yeah.
Yeah, so that's called the coronally positioned flap, and you can. They're not as predictable, or the evidence is that if you combine that with a graft, that's the best outcome. Okay. So doing a graft with a coronally positioned flap. So they used to do coronally positioned flaps a lot. That was kind of because before we did gum grafting or whatever. But the results are just mixed. It's not as predictable. Sometimes you can get a good result if it's not too severe, and we can use some other like medicaments to try and help with that. But usually you have to have some sort of a graft to kind of help stabilize everything and really get some attachment. It's a good question. Yeah.
So when a patient has a recession, does the sensitivity usually go away like within a couple of years, or does it stay for like, I don't know, forever?
Like if they have recession and just are complaining of sensitivity?
Yeah.
Yeah, so it can go either way. Sometimes they can, kind of develop they may have some like reparative dentin laid down in the root canal that causes them to not be sensitive. Most people will stay sensitive unless they do something, whether that be, changing their toothpaste to something to combat sensitivity, grafting, or, some sort of a bonding agent over it. But most people, I would say, have sensitivity for a long term.
So you're saying, so basically the treatment options for them are like Sensodyne, what is it? Desensitizer, and maybe gingival graft.
Sure. Yeah, those would be your options typically.
Okay.
Would patients be relieved of sensitivity once you do the graft immediately, or does it take them time?
It can take some time, but typically it's pretty quick because you're covering up the tissue that's sensitive. So like they're not having cold water run over it anymore, and so that helps. And it's I do sensitivity and dentinal hypersensitivity is an indication for a gum graft. Sometimes I saw a patient the other day who had like maybe 1 millimeter of recession, but she was super sensitive. And in her case, I didn't recommend a graft because I don't know that I'm going to be able to cover up that 1 millimeter and like make it way better. Right? Does that make sense? So that's when I'm like, okay, maybe we need to try something a little less invasive and, kind of go that direction. But yeah, typically it's a pretty quick relief for them. And they feel better fairly quickly.
So what did you do for that patient?
So she was going to try Sensodyne, and you can actually do like, sometimes I'll give them, oh my gosh, high fluoride toothpaste, Prevident, and that can help. And if that didn't work, if that doesn't work, we're reevaluating. But we may do like some gluma or something, like a bonding agent essentially over it.
Okay, thank you.
Yep.
Does doing like a bonding agent over the root surface interfere with the graft itself or the reattachment?
Yeah, so I'm not doing that in conjunction with grafting. So that's just essentially just
like, let's say like a week before or a month before, the general dentists just try to put bond on that surface and cure it to reduce sensitivity. Now they want to do a graft on the area. Is that an issue?
Not necessarily, because I'm going to clean that either way before, like I told you, I'm going to root plane it really well in ultrasonic. So I should remove anything that, even if it's, whether it be calculus or bonding. Yep.
So you clean it with ultrasonic, you don't do like etch or anything like that, right?
No, some people will do citric acid or something. I typically just root plane it really well, clean it really well.
Okay.
All right. Free gingival graft. So this is a different type of graft. Okay, so this is a gingival graft, but our goals on this are typically a little different than when we do the connective tissue or the alloderm. So the main reason we're using this graft is to increase the amount of keratinized gingiva that we have around the teeth. Okay, so in this case, we prepare the site a little bit differently. We do a little split thickness flap again, but we're actually making an incision right along that free gingival margin, maybe even not free gingival margin, mucogingival junction, maybe even up just a millimeter or coronal to it, and creating essentially a wound in the mucosa. We take the tissue from the palate, and it's a thin block of epithelium. So we're actually taking the epithelium with us in a small little layer of lamina propria. So if I can make my graft about a millimeter and a half, I'm feeling pretty good. So it's a thin tissue. We position it into that wound and suture it so it's not moving, but we don't cover it with our flap. So essentially it's a patch onto this wound. And we use, I'll show you a little, what's called a periodontal dressing to kind of hold it in place and hold the flap down. Typically, this is not used for root coverage. In the past, this was developed before connective tissue grafting, but now we know that connective tissue grafting is a little bit more predictable, so we use that more. So essentially, we're looking at number 20, and they're going to get I think they were going to do a partial or something, and they needed more. They wanted a little bit more keratinized tissue there. So on that upper right, we've made an incision like right along that, right above that mucogingival junction, and then I actually sharp dissection down a little bit. So in this case, I'm being careful. I want to know where my mental foramen is, but I'm making incisions and kind of cutting back that tissue. I'm leaving my periosteum. I want the periosteum to stay, so it's split thickness. But I'm creating a little bit of essentially an open wound there. When we take the graft, you can see that lower left, we just fillet off some tissue essentially. Okay, so it's just a block of tissue that we take off and then suture in place there on that lower right. This graft is typically more uncomfortable for the patient because there's just an open wound where the graft is taken. Okay, and that essentially will granulate in and will heal back to epithelium. But for the first, week or so, 3, 4 or 5 days, it's pretty sensitive. So a lot of times we've made them a stent that they can wear over it, so like a little mouth guard to just kind of protect it. But it just has to granulate in. But when that heals, then you can see there's like a nice big patch of keratinized tissue now. And this picture on the left is the periodontal dressing. So essentially what it is a putty that we use to cover and protect a surgical site. And we put a little bit on the lingual and a little bit on the buccal and press the tissue or press the dressing underneath the contact of the teeth. And it kind of locks in. Okay, it's fairly soft. It hardens, but it still remains fairly soft, and it just flakes off when we're done after a few weeks.
What is that putty called again?
It's called a periodontal dressing. There's different brands like Copak, Coepak. But yeah, we don't use it very much anymore. I use it for something like this, and I'll use it when I do a frenectomy as well, to just kind of hold the tissue down so that it doesn't just rebound and grow back. So I'll pack it on so that it's pushing down where I just removed the frenum. So you can kind of see this, it looks almost like a little tire patch, okay? So we don't use it very often in like an aesthetic area where they're gonna smile, because you'll have this nice pink patch where this graft is. But it's awesome for getting like more keratinized tissue, or like I've used it on like a patient who had an overdenture on their implant, 2-implant overdenture on the lower. And one of the implants was essentially just surrounded by mucosa. And so we put put a free gingival graft around it and got a nice little layer of keratinized tissue that was a lot easier for her to clean and keep clean. Again, so the success of this graft depends on survival of the connective tissue on the apical side of the graft. And so that's why we prepare that site with an open wound, so there's a nice blood supply, and we place it there. There's essentially 3 different healing phases for this graft. So the first 1 to 3 days is what's called plasmatic circulation. So essentially what's happening is nutrients are diffusing from the graft site, from the recipient site into the graft. So it's essentially diffusion of nutrients. Starting at day 2 up to 10, you start to see revascularization. So blood vessels begin to grow into the graft. Typically it begins at the periphery and then moves to the center of the graft. You'll see some of the epithelium slough off of the graft, and then it's replaced at the borders. It starts to move in. The connective tissue itself is what determines the type of tissue you're going to have grow back, which is why we take from the palate, because it's all going to be keratinized. And then by day 17, you have functional integration. So the graft is fully, essentially integrated into the surrounding tissue and starts to look and feel like gingival tissue. So the three phases: plasmatic circulation, revascularization, functional integration. Okay, any other questions on that stuff? Can you give me like 1 minute?
Yeah.
I heard the door at my office open in the back, and no one else is supposed to be here with me, so I'm just gonna go make sure that I'm okay. If you hear me scream, call 911. I'm in Kaysville.
Good luck.
Huh?
Okay.
Good luck.
Give me 1 second. No, I can't get out of this. All right, I'll be right back.
So if he doesn't come back, does that mean we're done for the day then?
Steven, get the arsenal ready.
That's what I was saying. I was like, he's got to conceal or something at work.
All right, I'm alive. It was just my assistant doing reminder calls, so I didn't know she's gonna be here. So we're good. All right, let me.
So I had a question, Dr. Jensen.
Yeah, please.
So when you use a periodontal dressing, it's either using that or a stent. You don't use both, right? To cover the healing area?
That's a good question. So, yeah, if hang on, let me just get this back to where we need to be. So if I was going to do, I used the stent to cover the palate.
Oh.
So so the stent is to cover where I took the graft from.
Mm-hmm.
The dressing covers the recipient where the graft goes. Now, if I were to do, like, say I was doing a graft on like number 3,
Mm-hmm.
and I was doing just free gingival or whatever, and I took the graft from so I took the graft from the palate of number 3 and put it on the buckle. Then in that case, I could probably just get away with using a dressing, and I just pack the dressing to cover both of them.
Around.
Awesome. Yeah. But the stent essentially is just to cover the graft where where we take the graft from.
And you ask the patient to wear it all day.
So I tell the patient it's their preference. So like, if they're feeling fine without it, they don't have to wear it. Essentially, it's just a comfort thing for them. If they want to wear it all day, they can wear it all day. I usually tell them to take it out at night, but it's a really soft plastic. Like, it's not like a rigid thing. It's clear, and it's totally up to them.
Okay. Thank you.
Yeah. All right. So the next section here is on implants, and I know Dr. Hegde already went through implant stuff, so I'll move a little bit quicker. But if something doesn't make sense, or if I'm like doubling up on stuff, just tell me to keep going or whatever. But please let me know. So just quick, we all know what a dental implant is. It's essentially a prosthetic device. We use it to replace teeth. Could be multiple teeth, could be all the teeth, could be one tooth, all sorts of different things. Most dental implants today are some form of titanium or an alloy of titanium, although we're starting to see a little bit more of ceramic implants. But again, the vast majority of implants are titanium based. There's 3 main components that we're aware of, that we know. Okay, so we have the implant itself. In the literature, occasionally you'll see it referred to as a fixture. So the implant is called a fixture in the literature occasionally. You have the abutment and then the crown. So there's 3 main parts to an implant, those sorts of things. And there's, again, we have screw retained versus cement retained, whereas in the screw retained, essentially the crown and the abutment are already fixed together. And in a cement retained, we have to cement them back together in our office. Just some terminology to be aware of that you'll see and may see on boards and things. So osseointegration is essentially the intimate contact between bone and implant surface. So that's what we want on our implants before we restore them. And for the long term is to be osseointegrated. You have peri-implant mucositis. And essentially that's inflammation around an implant limited to the soft tissue, and we don't see any signs of supporting bone loss. So this is something that we can typically get under control quickly, and we'd rather see it at this stage than the next, where we can make some changes to the patient's habits and in our cleaning and essentially reverse that. And then if not treated, then it could mucositis could move on to peri-implantitis. So again, it's an inflammatory process that we see around an implant. And in this case, you have both soft and hard tissue loss or inflammation. So you start to lose bone beyond what we normally see. So when we place an implant, typically as that implant heals, we see some bone remodeling in that process. So normally up to a year, you can actually see a little remodeling around the neck of the implant. And that's normal in most cases. Usually that's a millimeter or less, but you'll see a little bit of change. If we start to see more than that, then we become a little nervous. And especially if we're seeing bleeding and inflammation around the soft tissue, then we have to address that. Again, normally this is associated with bleeding on probing or suppuration and greater than normal bone loss. So a little bit on osseointegration. So this is what describes the connection between implant and bone. And it's a direct connection. So you have ordered, normal looking bone coming right up to the surface of the implant. The only way to really know if you have osseointegration is to look at it under a light microscope. And so, you know, we look at a radiograph. So we place an implant and we take a radiograph of it and try to determine whether that implant is healed or not. You know, we're looking for signs. We're looking for like radiolucencies, large radiolucencies around the implant, or bone loss around the coronal. But there's no way for us to really tell if this implant is truly osseointegrated besides looking at a light microscope. That's what that definition is. Now we do things like we'll palpate it and we'll percuss the implant. We can, you know, do some tests to check the resonance on the bone around it and see if that is, you know, a normal number. I don't do a lot of that, so I don't know that much. But typically what I do after an implant is placed, when I see them again at 3-4 months, I'll probe it, I'll percuss it, I'll take a radiograph, and, you know, typically that's enough to tell me whether that implant has healed or not. If I have a question on it, then I can do reverse torque the implant. So essentially what that means is take the healing abutment off, get my torque wrench, put it in reverse, and put a little pressure on the implant to see if it's loose. Okay, essentially I only do about 15 to 20 Newton centimeters, which is really a small amount. And if the implant's integrated, it's well over that to like back out an implant. It's really hard to just unscrew an implant that's integrated. And so those are things that I can do to test that. I just don't, there's no way to know if it's truly osseo-integrated besides looking at it under a microscope. But you have this intimate contact with bone. If you look at it under an electron microscope, there is a little tiny gap between the bone and the tooth. So it's not like they're just bone and implant. But essentially, to us, we don't see that gap unless we look at it really, really small. So just a couple things as far as healing goes with the bone around the implant. So once the bone is totally healed, again, we're going to see an intimate contact between the titanium and the bone tissue. Bone should look normal around an implant, so it'll typically heal normal. So you'll see the canals and the osteocytes right up next to the bone or to the implant and laying down normal looking bone. That's osseointegration. Okay, so you should have nice normal bone. This is just some stages of bone healing. This is from an orthopedic paper, but just kind of a good sense of what's happening after an implant's placed. So in the first week after injury to a bone, so an osteotomy essentially, you have the inflammatory stage. And so what's happening at this point is you have these cells starting to infiltrate the area, inflammatory cells and fibroblasts. And so they're signaled by prostaglandins, and they read that in the bone or in the blood, and then these cells start to move in. You start to see granulation tissue, vascularization of the area, so increase in blood vessels, and migration of mesenchymal cells that can then differentiate into different things. So there's this idea out there in some circles that anti-inflammatory medications may inhibit the bone healing. In my opinion, I still give people some ibuprofen after. I don't know that there's enough of an effect on bone healing to stop like an implant from integrating. But the general idea and concept is there, that if some inflammation is good, and that's how we heal. And so the idea is that if you give them a bunch of anti-inflammatory stuff, it may inhibit their healing. But in my opinion, if I'm just giving them normal doses over the counter, I haven't seen a problem with that. And so I still give them a little ibuprofen because I want them to be comfortable. Second stage is repair. So from about a month to 6 weeks. At this point, you start to see the fibroblasts laying down what's called a stroma. And this is what helps support the vascular growth. So you're seeing some increased vascularization in the area. This is one reason nicotine. So nicotine inhibits this capillary growth. So that's one reason why smoking is considered such a big risk factor for implants, is you just don't get as good a vascularization as you would without. It starts to then lay down the matrix. So the collagen matrix is laid down. The osteoblasts start to secrete osteoid, which will then become bone. And in this stage, immobilization is critical. So, we're trying to we're not trying to have them bite on the implant. We're trying to keep the implant stable. This is like initial stabilization or initial stability with the implant. So how tight it torques in is important in this stage. So if it goes in nice and tight, we feel pretty good that it's going to be stable throughout the healing. If it doesn't go in as tight as we like, a lot of times what I'll do then is I'll just put a cover screw on and replace the gingiva and leave the implant submerged, so that we don't want any movement in this stage. We want even micro movement. We try not to have any pressure put on it. And then finally, as that heals, that osteoid begins to harden, become bone. After that, we enter what's called remodeling. And so this can take place over months or years, but you typically see complete healing. And so normal, like we said, normal bone around the implant, everything looks healthy, and you have ossification of that collagen matrix that was laid down. So you have the inflammatory stage, the repair stage, and then remodeling. And remodeling can take place for a very long time. But initially, when I place an implant, that first 6 to 8 weeks is kind of like the prime time healing that I want to see. Them being really careful and in keeping the area clean and trying to stay off of it as much as they can. So a little bit about the sulcus around an implant. So typically, we do see some attachment to the implant itself, to the collar. This is mostly through junctional epithelium. So we don't necessarily see like a connective tissue attachment. Okay, there's some companies that will market that they have some evidence that they have this surface that's treated a certain way that has connective tissue attachment. But in general, you can assume that you have hemidesmosomes connecting to the titanium. So you've got a long junctional epithelium there. As far as the connective tissue around the implant, in the gingiva around it, typically you'll see collagen fibers that may approach the implant, but they're typically not inserting into it. If you imagine, when we think of a tooth, so connective tissue fibers around a tooth are typically perpendicular into the cementum, right? We have oblique fibers and parallel and circular fibers and all these other things happening. In an implant, the connective tissues in the peri-implant area are typically parallel to the axis of the implant. So they're not coming into and attaching to the implant. They're just running around the implant in a parallel manner. So if you have attachment to any part of the implant, soft tissue-wise, likely hemidesmosomes and long junctional epithelium, which is fine. We like that. We can keep that healthy. This is just a picture. Go ahead.
Yeah, so just a quick question. So when you do immediate loading of the implant, or I guess I should ask, do you ever do that? Do you recommend that only in certain cases? What are your thoughts there? Because you going through all the healing process sort of makes me think, hey, why do people do that?
So you can, and there's evidence that works. But a couple things, you have to have a really high initial stability. So like you're torquing it in and it's nice and tight. Okay. When if I do the temporary, I'm going to make it as much as I can out of occlusion. Right. Now that doesn't mean that it's still going to take some pressure, right? Even if I buzz it down and do a bunch of stuff, because if they chew on it, there's going to be pressure put on it. But I'm just really upfront and clear with the patient that you have to be really careful with this and try not to chew on it. And, it's going to look a little different. Like I'm going to make this tooth a little shorter maybe, and it's not going to, I just don't want it hitting on the tooth having occlusion. So it has to have a really good initial stability, and then I'm going to take it out of occlusion.
And so that initial stability, are you talking like more than 35 Newton centimeters?
At least 35.
Like where?
Yeah. What's that?
Like, so are you more comfortable with like 45, 50, or is that too high?
No, it's not too high, but if it's 35 or above, then you're in pretty good shape.
Awesome. Thanks so much.
Yep. So this is just a little, essentially illustrating what we just talked about. So you can see like those connective tissue fibers on the right where the implant is are more of a parallel. And you might have a little junctional epithelium attachment. A quick note, about what's called the micro gap. So the micro gap on an implant is where the abutment and the implant meet. And there's been a lot of studies done on where this implant gap is and how does it affect the healing and does it affect bone loss and that sort of thing. And so this is typically where we see the localization of bacteria is in this area of the gap. And the reason that is it's number one, it's a break in the smoothness of the titanium, and you also have micro movement there where the implant moves slightly, or not the implant, the abutment connected to the implant moves slightly. So there's different ideas and different ways to manipulate this micro gap to try and preserve bone and prevent loss of bone. So if you look at the first one on A, so this is like a butt joint. So the micro gap and of the implant and the abutment is right adjacent to where your bone level would be, and it's right on the edge of the implant and the abutment itself. So this is like this is the traditional what implants look like a lot at first. So if it was bone level, you had a butt joint there, and that would cause some bone loss because you have micro movement and maybe bacteria aggregating there. And so what the idea is that could lead to bone loss being so close to the bone. So in number B, what we've developed is we call it a platform switch. So essentially what we're doing is making the abutment a little bit thinner than the implant itself, so that when you attach the abutment, the micro gap is moved in towards the center of the implant away from the edge. And that has shown to lead to a little less bone loss when butt joint on the end. And so a lot of the implants we use today are platform switch. So they use a little bit thinner abutment connection than they do on than like right towards the edge. And the idea there is to save bone. Another way to do this is to put the abutment and implant connection up above the bone at the soft tissue level. And so that's called a supracrestal connection or a gingival connection. And so you're just moving the a connection coronally. It's a little, there's some challenges there with aesthetics. So this is mostly, I did a lot of these when I was in residency at the VA, and we use these typically in the posterior, and they look really good for the most part, but occasionally you'd see a little collar of implant at the gingival level. But they're very stable because that implant, that micro gap is moved up and away from the bone. So there's nowhere for that to happen, and nowhere to cause bone loss there. Does that make sense? What a platform switch is? Essentially moving that micro gap towards the center of the implant by using a smaller diameter abutment than the implant. Okay, this is just a, these are some things that you may see on your boards. So bone quality can influence osseointegration. So typically, some areas of the jaw come with thin layers of cortical bone and large cancellous spaces. Others are opposite. They have a thicker cortical bone and less cancellous. So like mandible is what we think of there, especially anterior. So bone that is less dense can have lower success rates than bone that is more dense. So we tend to see a little bit higher rate of implant failure in maxillary posterior when compared to, say, maxillary or mandibular posterior, just because typically that bone is less dense and can cause some issues as far as healing. So we have a way to rate bone quality. And so, again, this is just like generalization, because not everywhere is going to be that I say is type 1 is going to be type 1, right? So, but we typically say type 1 bone is high cortical bone, small cancellous. Typically, we think of mandibular anterior for type 1. That's kind of where you see it most likely. Type 2, again, you've got a little less cortical bone, but still quite a bit. Mandibular posterior, typically type 2. Okay. Number 3, type 3, cortical bone, but a lot more cancellous, maxillary anterior. And then type 4, very little cortical, lots of cancellous, maxillary posterior. So these are just generalizations. Okay. It's typically what we see, though, is bone in the mandible is more dense than bone in the maxilla, and bone to the anterior tends to be a little bit more dense than bone to the posterior. Okay, so just a kind of a review there. A couple of things to consider if when doing implants for patients. So we go through their medical history, right? Typically, there's very few real contraindications to implants. Smoking is a big one, and as well as uncontrolled diabetes. Both of those affect healing, and especially healing in bone and soft tissue. Periodontal disease is something to be aware of. So if a patient has uncontrolled periodontal disease, we have to be really careful with their treatment. We have to make sure that we stabilize them before we do an implant, and we have frequent follow-up. Chronic steroid therapy, again, that can affect inflammation and healing. High dose radiation, again, that can really affect bone healing, much like bisphosphonates. Alcohol abuse is there. It's not as high as like smoking, kind of similar to what we talked about with periodontal disease this morning. So these are some things to be aware of. Have I put an implant in someone that smokes? Yes. Did I have a conversation with them before I put the implant in that you're at a higher risk for failure? Yes. So they have to be really aware of what they're doing. And I have them sign that consent form and make sure that they understand what the risks are. And obviously kind of talk about quitting, but that's a hard thing for a lot of people to do. So just a list there of some things to really be aware of when you're doing implants. So, we want to make sure that there's no pathology. So again, we're treating them for any gum disease, or we want to get their caries taken care of and all that sort of stuff done. The bone looks healthy on a cone beam. They have adequate keratinized tissue. And then obviously the ridge dimensions, we have enough area to actually place the implant into the bone. So cone beam is going to help you determine a lot of this, as well as a clinical exam and periodontal exam. These are, again, kind of just things to be aware of, vital structures that we're working around in a lot of these. So we have the mental foramen, the IAN, the sinus, a nasal cavity in the anterior on the maxilla, and the sublingual artery on the lower. Obviously everyone's going to be different. So how do we do this? We take cone beam. We can do a PA or a pano or whatever we feel like we need. But right now, essentially the standard of care in most cases is a cone beam to show us where landmarks are, where anatomy is, how much bone and that sort of thing. One thing to be aware of on this is a lot of implant drills will extend about 1 millimeter apical to the implant length. So when you measure on an implant drill at 9 millimeters, the line, they'll, whatever, 10, they have marks. That drill is going to extend about a millimeter down below that to cut down just a little more. So just be aware of that when you're planning things, that my drill is going to be just slightly longer than what my planned implant length is in most kits. And you can measure that obviously before you do anything. Take a probe and make sure, but just be aware that's something that you'll be working with. What are our defects? What are our hard and soft tissue defects? Are we going to have to do some bone grafting before we place the implant? Do we have to graft when we place the implant? These are all things that you want to be thinking of prior to doing any surgery, so that you and the patient understand what's happening and what needs to take place. Do we have to do some augmentation before we place the implant? Do we have enough soft tissue? Are we going to have to rebuild that as well compared to the bone? These are all questions to take into consideration. So sinus, sometimes that sinus, the maxillary sinus is encroaching on the space where we want to place our implant. We have to augment that. So typically, in a lot of cases, we can do what's called an indirect sinus lift. And that is done at the time we place the implant. So in most cases, we have, enough bone, residual bone to place the implant and get a good torque, but we still have a few millimeters into the sinus. So in this case, we take our initial drill and go just short of the cortical plate in the sinus, and we can take radiographs and measure and see where we're at, and then we go to our size and we use what's called an osteotome. It's essentially like a little plug or a little rod, and we tap on it with a mallet and infracture into the sinus, and then we do it gently. We're not trying to smash it and hit them really hard, but as we do that, we tease that membrane up, and then we can actually place bone through our osteotomy, as you can see in the picture, to create a little dome, which then our implant can be placed into that, and it has a little bone at the apical portion there. There are other techniques and drills that we can use to do this, and that kind of push up into the sinus rather than just cutting away. But the classic approach is to use the osteotome. If there's less than 5 millimeters of bone, or 4-3 left, then we usually have to do what's called a direct sinus lift, where we actually cut a window in the lateral side of the maxilla and tease the membrane up, and then actually directly place bone into the sinus, and that gives us a little bit more height than we can get with an indirect lift. And so this is just illustrating a direct lift. So we open the sinus from the lateral side, elevate the membrane, place bone graft into the sinus. Usually we'll lay a membrane over that and then suture back.
So how much time in between a sinus lift and when you could place an implant?
Yep. So with the indirect, we can place it right away. The one where we don't need as much, you can usually just place your implant. On a direct lift, in most cases, we're waiting about 5 to 6 months.
Okay.
Some people will place implants immediately if they feel like there's enough bone to get a little initial torque. I more lean towards doing the graft and then coming back and placing implants. It's about 5 to 6 months.
So what do you want to see clinically and radiographically before you go and place the implant after you've done a sinus lift?
Yep. So clinically, I just want to see normal, healthy gum tissue. I'm not going to really see anything like bone-wise, right? But then, I'll take a cone beam, and I want to see normal, healthy bone. And you can sometimes tell it's a graft. Like, it'll look a little grainier than, say, like just normal cortical bone or something. But by that time, it should be ossified and hard. And normally what I'll do is I'll take a pano right after I do the graft. So we'll like do this and then suture them and go take a pano and just see where everything is. And then when I take my cone beam, we can kind of compare, and it should be fairly stable. Okay. And then it's just a normal implant. Then you just doing your normal osteotomy.
What's the most height you could gain from a sinus lift?
You can get a lot. It just depends on what type of implant you want. I mean, 10 millimeters is doable, for a standard implant. You just have to be. You don't want to go too high because you have an ostium where the hole is,
right?
Where, the sinus drains.
On our itinerary.
And so you have to be aware of that. Like you can't pack too much bone in. That'd be a lot of bone. Like you shouldn't do that. Yeah. But you can get quite a bit. You can get enough to where you can place a nice implant.
Okay.
Do you have to refer the patient to the oral surgeon if you accidentally tear the sinus?
So yeah, so the biggest challenge on these is not tearing the sinus membrane, and they're really thin. It can be very thin, and there are some ways to work around that. As far if you do have like a little tear or something, you can continue going. You can finish, but yeah, this is something that you would want to have a lot of probably practice on before trying one. It's a pretty delicate procedure. So let's just talk a little bit about immediate implants. So this is something that is big today, and a lot of people want to try and do this, get an implant in as quick as they can. So just some ideas and information on that. So in indications for this typically are it's a single rooted tooth. Okay. Typically you want to have a nice intact socket. So you want to have buccal wall, lingual wall, interproximal bone, free from pathology. So like we look at this x-ray on the right, putting an implant there at number 21 immediately is probably not your best bet. Quite a bit of pathology there. You want to have some bone apical to the socket to get good primary stability. So you're going to drill down into the base of the socket, apical to it, to get your initial stability. So some of the contraindications again would be like big infection or bony walls missing. So this is a good example. So you have this number 8 that's just fractured off at the gum line. You extract that root and determine that you've got some nice bony walls, and an implant is placed. And in this case, it wasn't temporized, and there's a healing abutment placed, but it looks like it's healed up real nice. You see that nice tissue there. So in this case, again, so here's some immediate loading for what we were talking about before. Okay, so we want to have a protected occlusion. Okay, so it's nice to have adjacent teeth around it so that those teeth can take the bulk of the pressure. We typically think of this more in the aesthetic zone than we do in like a molar or something like that. Again, there's that 35 to 45 torque, so we want to have a good initial stability. The contraindications here would be if you need to like do a big augmentation on it. If the implant needed bone grafting right away at the time you placed it, you're probably not going to temporize right away. Again, obviously lack of primary stability, and if you cannot protect the occlusion, so you don't want to have it being the main tooth occluding in the function. So these are just kind of basic things that should make sense. So we want to have healthy bone, right? So we want the bone to heal and be normal. Atraumatic and aseptic technique. So we're using, we're keeping things clean. We're using proper sterilization. We're using irrigation on our drill because we don't want to heat the bone. So good irrigation. Some drills are internally irrigated. Others are just external. So some will actually pump water through the drill. Others just spray water onto the drill. once the implant is taken out of the case, we shouldn't touch it with our gloves, instruments, the suction tip. We should keep that area as free from saliva as we can, and immediately put the implant into the osteotomy and start to place it. The heat thing is a big one. So when I'm doing an osteotomy, typically I'll pump my handpiece. I won't just push and go all the way to 10. I'll go down a little bit and kind of pull back and up and down, and that gives the drill the chance to clean and to cool. Some indication or considerations as far as spacing. So typically with an implant, we want to be 1.5 to 2 millimeters from an adjacent tooth, and at least 3 millimeters between implants. And the reason for the 3 millimeters between implants is, like we talked about earlier, a lot of times on implants, you're going to see a little remodeling of the bone around the collar or the coronal aspect of the implant. And if you place the implants too close together, then those remodeling zones can meld together, and you'll get essentially bone loss between the two implants, and you may lose like some papilla, and your aesthetics may suffer a little bit. So you want to have a little extra space between the implants so that you can keep a nice interproximal tissue level. You get a little less of that between, oh, go ahead.
Sorry, I have a question about immediate loadings. You mentioned one of the contraindications is that if you need bone grafting, you're going to do that. When would you determine you need bone grafting versus not needing it?
Yeah, so say, like, you may know that before you place the implant. Like, okay, so I know that this bone is thin and I'm going to be grafting it. I'll tell the patient we probably can't temporize because I have to graft this to make it a little wider. So like before the procedure, you may know that with a cone beam, right? Or you take a cone beam and it's unclear, and you go in there and start to drill and realize that it's thin, and you're going to have to bone graft on the buckle to increase your bone there. Then you're going to say, hey, we can't do this, right? We can't. It's just, there's too much going on here to then temporize, because a bone graft really needs to be immobile and stable. And if you put a crown on that and start to get a little movement, then you're going to compromise that bone graft.
Okay,
typically,
sorry,
go ahead.
I was thinking, because if you need a bone graft, then maybe immediate placement of an implant isn't the best option. But I guess
this is loading.
Yeah.
So putting a crown on.
Isn't this after you do an immediate implant placement?
It can be, or you could immediately load after you place it into a healed socket.
Oh, I see. Okay.
Yeah. So if you do an immediate placement of an implant, typically you're going to need some bone grafting into the socket, and that's a little different. Like, you could probably temporize that, where you're like, say you place your implant into like a socket, you're going to have like a little space around the implant, right? Typically it's not like big enough to fully fill the socket. And so that's a little different. But if I'm placing an implant where I need like to augment a little bit with no wall, I'm just putting implant like on the buckle aspect, then I'm a little less likely to load that.
But that would be like a bony defect then, right? Because you don't have that buckle wall.
Right.
So that falls.
So that's what I'm saying. What's that?
So that falls under one of the contraindications for immediate implant placement then, right?
Correct.
Okay.
Good?
Yeah.
Okay, awesome. Okay, so 1 stage versus 2 stage. So essentially a 1-stage surgery is when we place the implant and then immediately put on a healing abutment. So this is, again, we want to see some primary stability, and we don't necessarily have to do a bunch of augmentation. We can just place our healing abutment, and then in the 3 to 4 months, it's ready to get restored. A 2-stage is when we place the implant and maybe we don't have the torque value we want to see initially, or we have to do some pretty extensive bone grafting. we'll put the cover screw on, replace the flap, and let it heal. At the time when it's time to restore, we have to go in and do another procedure where we make our incision, expose the implant, and put a healing abutment on. So essentially there's 2 steps on that. So in most cases, I'm trying to do 1 stage if I can, because it just saves the patient another procedure, and place our healing abutment. So a 1 stage is healing abutment placed at time of implant placement. A 2 stage is cover screw at implant placement, followed by healing abutment attachment afterwards. We kind of went through this already, and I know Dr. Hegde kind of touched on that. Is there any questions on the mucositis versus implantitis? Oh, it's not going to give me the gifts. I'm sorry. That's disappointing. So just some terminology. Ailing. So an ailing implant, we would term an implant ailing when it has peri-implant mucositis. So it's starting to see some problems. And so an ailing implant can be turned around and can be reversible. A failing implant is when we have peri-implantitis. So we're starting to see bone loss beyond normal limits. And so the implant is starting to fail. A failed implant is when it's mobile or we've taken it out.
Are we considering peri-implantitis irreversible?
So it's no, but we don't have like a really great way to treat peri-implantitis. So typically it's we're trying to do everything we can to stabilize the implant. If it's an early stage of peri-implantitis, then typically you can, kind of control it and maybe even get a little bone growth back with some grafting. Some of the more advanced stages of peri-implantitis, you start to have this conversation of whether it's worth, trying to just kind of keep the implant and baby it or remove it and start over. So, peri-implantitis is like a fairly new thing, right? Since we've been placing implants, and it's tough to treat because it's not like treating a tooth necessarily. There's less blood supply and less like stem cell population to use when we're trying to graft in different things. But I don't know that I would necessarily say it's irreversible, but it's really hard to reverse. Does that work?
Yeah, I was just curious.
Yep. So maintaining an implant. So, routine maintenance is going to be important. So patients still need to come and see you for prophies and things to clean the area and to clean the implant. If a patient is on a regular maintenance, is regularly seeing you and is coming back for their cleanings, they have about an 11-fold decrease in the chance of having peri-implant problems. So if they're getting their regular maintenance and taking care of it, then in most cases they're going to be just fine. If patients have a history of periodontal disease, then again, they should be kept in their routine maintenance that they've been having, which is probably more frequent than someone without, because they just have that risk of periodontitis, and that can carry over into peri-implantitis. So again, it's just, there's plenty of studies out there that show that long-term maintenance is essential in reducing the risk of peri-implant disease. So this is just some suggestions on what routine maintenance for dental implants should be. So we're checking the condition of the surrounding soft tissue. We're checking the plaque. We probe. We're checking BOP. And something to note that BOP is a little more likely to be false positive with implants because, as you remember, there's not that connective tissue connection to prevent our probe from penetrating tissue. So just probing those sulci can sometimes cause bleeding, even if it's not truly inflamed, because it's just less resistant to our probe. We're monitoring keratinized tissue. We're monitoring for recession. We're checking mobility, occlusion, and an annual radiograph is recommended to just monitor the bone yearly. So obviously the goal of all of this is to just keep the implant plaque-free and healthy for the patient, avoiding implant inflammation. So we kind of touched on some of this as far as risk factors for dental implants. So diabetes, especially uncontrolled diabetes, smoking, periodontal disease, other genetic factors, meaning, a propensity for inflammation, poor healing, those sorts of things. Residual cement is a big one. You can see that on that picture on the upper right. So when we're cementing our crowns, we have to be very careful that we don't put too much cement and that we clean it well. And it's hard sometimes to see on a radiograph, because if that cement's right on a buccal or lingual area, it may not show on the radiograph because it gets drowned out by the implant itself. Obviously, poor plaque control. So if a patient is not cleaning well or is unable to clean, it can be tough. Some of these, some of the implants, some of the crowns that we place have a poor contour, and it can affect the cleaning of the tooth. Or if something has to have a ridge lap or something like that, it can be tough for the patient to clean. So we have to be really vigilant and help the patient understand what needs to happen as far as the cleaning goes for them. Occlusion can cause an implant to fail if it's overloaded and takes too much pressure and force. We talked about head and neck radiation affecting healing of the bone. And then implant location can also affect the outcome. So we're looking at bone quality. We tend to see more failure in the maxilla than the mandible, probably because it's a little less cortical bone, less stability in the placement of the implant, and that can lead to some failure with implants. So what are some things we can do to prevent having problems in the first place? So initially, this begins at the time we place the implant. So having the implant immobile is critical. So primary stability depends on the implant design. So a lot of times now we're seeing tapered implants and a little different threading to kind of try and get that fit and that torque at the time we place it. We're trying to not have any micro motion between the implant and the surrounding tissues. So again, torque is important there. Cortical bone, we like to see that and engage that, because that gives us a little better stability at the time we place it. And we tend to see, with cortical bone, you have more dense bone. So if the implant is engaging that bone, there's more implant to bone contact, leading to, in theory, better stability over time. We want to properly plan for restoration and check our occlusion and make sure our occlusion's on point, so that when the restoration is placed and fitted, that it's not overloading the implant. And then maintenance. So like we said in the slides before, that the patient needs to understand that long-term maintenance of an implant is what's going to be the key to being successful there. A couple of things here. Periimplantitis, typically the defect around an implant is a little different than around a tooth. So on teeth, like we talked about, a lot of times we'll see like a vertical defect or localized defect. But in implants, a lot of times what we see is like a circumferential defect around the entire implant, and it can become saucer-like. And the question becomes why. And there's a lot of theories as to why that happens. Some theorize that the threading on the implant just leads to more bacteria moving down the implant. They term it like a slide or like a roller coaster or something. But typically, we don't know necessarily why. But these defects are much different than we see in teeth, and it can be difficult to graft those if they're wide and totally circumferential. But occasionally that can be to our benefit if it's able to contain the bone better. Sometimes we can see some improvement after grafting. So we may see some different organisms, microorganisms in the peri-implant tissue. And so that could be one reason why we see a difference in defect. Obviously, the surface roughness of implant is different than cementum, so that's going to cause us to see some different defects. most of the surfaces on these implants are roughened through different processes. Exposed threads, again, can look like an overhang on a tooth or a restoration. So if a thread becomes exposed, it can act as an overhang and trap bacteria. When we look at the sulcus of an implant, so in a healthy sulcus around an implant, they have a low bacterial count, and it normally resembles that of gingival health around teeth. So in a healthy implant, in a healthy mouth, typically you're going to see pretty similar microorganisms in the sulcus of the implant versus the teeth. However, pathologic sulcus does differ from teeth in an implant to a regular tooth. You see an increase in gram-negative bacteria, much like periodontitis, and those lead to inflammation and destruction of tissue. So the question then becomes, how do you treat this once it starts, and how do we help patients keep their implants and be healthy? So realistic treatment goals of these things should be removal of the etiology. So get rid of the plaque, get rid of the bacteria, the calculus. If there's cement on the implant, certainly we need to remove that. If there's occlusal problems, then we need to adjust that and address that. Once we remove the inflammation, then we can at least stabilize the area and then talk about and look at maybe regenerating or bringing that back. So this is just, and I know Dr. Hegde is going to talk about, or has talked about that, but this is just something that I've found kind of helpful in trying to kind of organize my thoughts as far as what am I doing in these therapies, and what am I trying to do, and how do I organize myself? But this is from a paper by Dr. Lang. It's called Cumulative Interceptive Supportive Therapy, or CIST. It's a CIST protocol, so around an implant. So it's kind of just a flow chart. So if my probing depths are less than 3 and I don't have any plaque or bleeding, then obviously it's healthy, so there's no treatment needed. However, if I start to see plaque and BOP, but there's no probing depths are still small, then essentially what I'm going to do is debride the area and clean it, and be essentially doing a prophy or maintenance. If my probing depths then start to increase, so I start to be 4 to 5 millimeters, then antiseptic cleaning may be in order, which would be using like a chlorhexidine rinse, or irrigating the area, maybe like Arestin or Atrodox. And then if my probing depths start to get to 5 or above, then it's time to start exposing radiographs and looking at bone loss. If we start to see bone loss, then we can do, if it's slight loss, we're less than 2 millimeters, we can start to do systemic or local antibiotic therapy in addition to antiseptic cleaning and debridement. And if our bone loss starts to increase over 2 millimeters, then we start to look at doing surgical therapy, so flapping and possibly bone grafting. So with periimplantitis, we don't have like a slam dunk treatment at this point where we can, just do this and everything will be fine. We have to really kind of look into our arsenal and the things that we have, and a lot of times we're using everything and trying to just be really aggressive in treating some of this stuff. Actually, the best way is to catch it early and have patients on maintenance where we see it quickly and can nip it in the bud before it gets to the point where we're losing a bunch of bones. So that's all I had this morning, and I guess for the day. I talked a lot. I'm going to have to drink some water. Any questions? Anything on that stuff?
Are you a fan of screw retained implants versus?
Yeah, I mean, if it's possible, I would prefer a screw retained. That I think it just makes it easier to do different things if we have to. So, like, whether it be retrieve the crown or avoid any any type of cement getting down in there and causing issues, I think it's great. Sometimes that's not possible. So you have to be realistic.
Possible?
Like on the maxillary anterior with angulation of bone there, it's just not going to be possible. There are companies coming out with different types of screws that may make it a little easier now. We can do some angled stuff, but you know, sometimes the angulation of the implant, it's just not possible to have a screw channel that's aesthetic.
Now they bring up angle. How much can angulation can you compensate with abutment?
That's a good question, from what I remember, I think it's probably around like 25 to 35 degrees on some of them. It can vary depending on the type of implant, but it's a pretty decent amount. It's not like teeny, but obviously we strive to not have to do that, right? But I mean, if you do enough, you'll see some that are just you have to struggle with, you know.
Yeah.
Dr. Hagdade, so do we have a lecture tomorrow afternoon?
No lecture tomorrow afternoon. You just have a practice test. That will only be available at 1 o'clock. I strongly recommend you taking that test if you can. You don't have to do it tomorrow. Probably, but it's very, very representative of how your test is going to be. Wink, wink. So please, please, please do that. Your recordings are available for the last 2 sessions. I just saw it. Jackie has already uploaded those. I'll have today's recording available as soon as it's available. Jackie's going to upload that. So that's that. What else? Jeff, that was excellent. I don't know how you spoke with so much, you know, I don't know. You spoke for a long time, and thank you for doing that. I really, really appreciate it.
Yeah.
It worked out well because it's absolute chaos in my house today. My daughter, who's 2 years old, is having a meltdown, and people with kids. I see a lot of you with kids around too in the video in the background, so you can understand how it's going. It's like all my arms are occupied keeping my mouth shut while I'm talking. And anyway, so thank you guys. I really appreciate it. All the recordings will be available, and I and Dr. Jensen are more than available over emails to answer questions. As you all know, Thursday morning we will do a review. So if you have any questions, we can talk about that then as well. Just as a side note, everything that Dr. Jensen has spoken about in terms of implants and in terms of all the lectures, those are given. I think those are very important from your exam perspective. The lectures that I gave are not necessarily important from your exam or your test. It is, you know, my lectures hardly have any notes on them. That's all about, you know, just clinical pictures. So if you're prepping for the test, I would recommend you go over Dr. Jensen's PowerPoints much more. And then tomorrow morning, you have a recording on PROS. It's about 3.5 hours. It takes you to an external source. It is basically a recording that's made available through the Maxi course. So you just have to put in your name and your email address so we know. Do not distribute this to anyone outside of Roseman. You cannot distribute this. This is just available to us. So please be mindful of that. That recording is available for you even now. So if you wanted to do this afternoon, you can. Again, it's 3.5 hours. It's about PROS and, you know, a lot of questions about the abutments and why not screw retain, why cement retain, all of that will be taken into because I and Dr. Jensen, as much as we know, we still are, you know, surgically inclined. That lecture is from a prosthodontist, so he goes in depths that we don't have the brains to analyze. So feel free to go through that or go through that recording and take notes. And we both are here if you have any other questions.
So tomorrow we're not logging in for anything, right? There's no sort of lecture over Zoom. Just the
Sorry, we can't. Can anyone hear, or is it my internet or hers?
No, you can't.
you hear me now?
No, do you want to put that in the chat? Maybe I can read it from there.
Day, how long is the assessment is going to be available?
Which assessment?
So the one that opens up tomorrow at 1.
Oh, it will be open throughout after that.
Okay, thank you.
Will that practice assessment be available for multiple attempts?
I think yes. If not, I'll
Okay, thank you.
Sorry, I kept talking when I was on mute. I'd rather you just do it once, if it's possible, just because it will help me go through those questions and see how you guys are doing. Because if you keep repeating it and if you remember it, then the analytics wouldn't give me a good idea of where you guys are. So I recommend you do it once. You're free to write those questions down if you wanted to, or whatever you want. But I'll make it available so you can take it multiple times, just in case you want to, okay?
And the final exam is still 60 questions, is that correct?
It is 60 questions. I've added 4 more questions as a bonus. So if you get those, then, that's that. So it is in total, you'll be tested for 60 questions, but 4 questions are extra questions. So, if you get them right, then it will kind of just add on. So that's that.
Okay, thank you.
I just have random questions. So I am curious about, let's say, if you're restoring an anterior tooth, why would you choose, let's say, titanium versus ceramic implants? Because in my understanding, I would always choose ceramic, because if you do have some kind of recession of the gingiva, you don't have the metal seeping through it. So I have seen one periodontist who always use ceramic on anterior teeth, but then others I have noticed that they don't really prefer that. So I was wondering, is there any kind of reasoning for that?
I mean, I think for me, it's just lack of experience. Like it's just, they're not as common. Another thing is the initial, they're different now. The initial ceramic implants that came out were essentially one piece. And so like the abutment and the implant were all fused. So there was no changing angulation. So once that went in, like it was in, and the crown had to fit to that. I think now they've got some more that you can actually kind of put abutments on a little differently. But initially it was like a single piece implant. So you had to put it in whatever way it went in was how that abutment was going to fit. Does that make sense?
Yeah.
And so that's a challenge.
If you, let's say, have a fairly good angulation, that would possibly be a benefit, since your abutment and your implant are one.
Sure.
You don't have that microbes gathering around that area.
Sure. Right. And I agree on that. There's just not as much evidence on the ceramic implants. They're becoming much more popular. So I'm assuming at some point it'll be more used, I guess. But I guess just from my perspective, I was trained to use, a titanium implant, and in most cases it's fine and it works great. But yeah, and that's one of the selling points of a benefit of a ceramic implant is if there is a little show through, it's not like this gray titanium. It's more of a natural color. But I guess that's my 2 cents on that.
Thank you. My other question was, how common is it to use, let's say, a stump of a tooth, if a tooth broke off, to use it as a guide for placing an implant? Or is that beneficial? So let's say if the tooth broke off pretty much at the gingiva, and you just use the tooth itself, more so on molars with. Yeah,
like drilling through it?
Yes.
Yeah, so I don't know that it's common, but it's something I've seen several times of like they'll kind of leave the roots in place so that they can drill down through the furcal bone and kind of use that as a guide. And I think that's fine. Then they extract the roots and then place the implant at the end. But
would that not affect the implant placement if you're placing it, but then you're extracting the roots around it? Wouldn't that just kind of like?
Yeah. So I would. So I know I don't do it. So that tells you one thing. But I don't think it's a bad idea. I would take the roots out before I place my implant. So like I would drill my osteotomy and get that already, and then take the roots out and then place the implant. So that would probably not affect it all that much. But yeah, does that make sense?
Yes, it does. And last question, I don't know if I've missed that, but when you're placing an immediate implant, what torque would you want to have it at?
Yeah, so ideally you're at like 35, right? And that's why you want...
35 is something that's average that you want for any implant. But if you're placing an immediate implant, would you want it to be lighter or?
Oh, I'd want it more, if anything.
Why?
I want a higher torque because that's going to be more stable and less movement, like micro movement. And because with an immediate implant, typically you're placing it into a socket, like we talked about earlier, and like you're not going to get as much like engagement on the walls of the socket because typically the socket's bigger than your implant in most cases. And so all of your torque's going to come mostly from apical bone, like above the socket. So you want, anyway, I want more torque to stabilize this implant that's going to be kind of hanging out into this socket. So like you'll see a lot of like implants that people use for immediate stuff is they have like a lot more aggressive threads. It's like Nobel has a type of implant called the Nobel Active, and it looks like a wood screw. It's got like really aggressive threads, but that gives you that torque because you want to have a little more torque because you're engaging less bone.
Okay.
Does that make sense?
Yes, it does. Thank you.
Good.
Okay,
did you see that chat, Dr. Hegde? I didn't know how you wanted to answer that.
Which one? Okay, no lecture tomorrow, so you guys are on your own.
Okay.
The recording and the test. So that's that. Feel free to email us again if you have any questions. I know this is hard for you guys not being physically there, but take your time, go through the recordings, and we're here to answer questions. Okay.
Awesome. Okay.
Thank you very much.
Thank you.
Bye.
Thank you, Dr. Jensen.
You're welcome. We'll see you.